We all use benchmarks, don't we?
Right.
Aiming for that fitness goal, hitting sales targets at work. They're supposed to show us what good looks like.
Right. Our North Star, sort of.
Exactly. But how often do we really stop and ask if these targets are truly achievable? Or are we sometimes just chasing an illusion? Especially when the stakes are high, like in healthcare.
That's a really important question. I mean, Webster's defines a benchmark as something that serves as a standard by which others can be measured. Pretty simple.
Seems straightforward.
Yeah, but the reality, particularly in healthcare settings, is that many benchmarks have been, well, quite subjective, often based more on who looks like a leader rather than solid, hard data.
Ah, okay. So maybe not representing something genuinely achievable then.
Precisely. They might be more aspirational than practical,
Mm.
not reflecting a level of excellence that can actually be replicated reliably.
So if these subjective benchmarks are a problem, how do we fix that? How do we make them, actually useful?
Well, that brings us right to our deep dive today.
Perfect timing.
We're looking at a really foundational 1998 paper by Kiefe and colleagues. They introduced this rigorous, data-driven method called Achievable Benchmarks of Care, ABCTM for short.
ABCTM. Got it. And our mission here.
Our mission is to explore if this approach really offers you, the listener, a kind of shortcut to being genuinely well-informed about driving quality improvement, not just in medicine, but maybe anywhere.
Okay, so breaking free from those potentially flawed subjective standards.
Exactly. The authors back then argued that the old way, just picking supposed leaders subjectively, often set targets that weren't really grounded. They insisted that for benchmarks to be meaningful, to be actionable, they have to rely on objective criteria.
Makes sense. Needs reliable data.
Reliable and validly measured data. Absolutely. Otherwise, you're not just comparing apples and oranges. You might be comparing, like, a real apple to some mythical golden one nobody can actually grow.
Okay, so let's unpack this ABCTM thing then. What are the core ideas?
It's built on 5 key premises, really principles for any sound benchmark.
Lay them on us.
Okay. First, benchmarks have to represent excellence, high quality. Second, they must be demonstrably attainable. Someone, somewhere, is actually achieving this.
Realistic, not just a dream target. Okay.
Third, you select those high-performing providers or teams using reliable, predefined data. No guesswork. Fourth, all the providers you identify as high-performing should contribute to setting that final benchmark level.
So it's a group effort from the best.
Right. And fifth, this is important, providers who did great but only had, say, 1 or 2 patients, those small numbers shouldn't unfairly skew the whole benchmark upwards. It needs stability.
Right. Avoids outliers having too much weight. So how do they actually do that? Calculate it.
They introduced this specific technique called the paired mean method.
Paired mean.
Okay, so first step, rank all your providers by performance, best to worst on whatever measure you're using.
Simple enough.
Second, starting from the very top performer, you keep adding the next best and the next best until the group you've collected represents at least 10% of the total patients in the whole data set.
Ah, wait. Patients, not providers.
Exactly. That's key. It ensures the benchmark reflects performance across a significant chunk of the actual care being delivered, not just a few small, perhaps unusual providers.
Okay, that's clever.
Yeah.
So you gather this top 10% patient cohort, then what?
Then, third step, you calculate the benchmark level based only on the average performance of that selected top group. It filters out the lower and average performers to find the achievable high standard.
Wow, okay. That sounds much more rigorous. Is there an example of this in action?
Oh yeah, the paper has a great one. From the Cooperative Cardiovascular Project, looking at heart attack patients.
Okay.
For smoking cessation counseling, that's something pretty basic you'd think. The overall average performance across 106 hospitals, just 14%. 14.
Ouch. That's low.
Very low. But using their ABCTM paired mean method, they identified just 12 top-performing hospitals. And the benchmark derived from them, 49%.
49. That's a huge jump from 14.
Massive difference. It shows that level is achievable, just not by everyone currently. It makes the goal concrete, not some vague ideal. That's the real shortcut, knowing what good actually looks like based on real achievers.
Okay, but what about that point you made earlier about the small numbers? Like, a clinic sees one patient, counsels them, gets 100%. How does this paired mean handle that?
Great question. They address that directly. That 100% from one case isn't statistically robust, right? So they bring in another tool, a Bayesian estimator technique.
Oh, sounds statistical.
It is, but the concept is simple. It's a way to get more reliable estimates from small amounts of data. They use a specific formula called the adjusted performance fraction, or APF.
APF formula.
Pretty neat. X plus 1 divided by D plus 2, where X is the number of times the thing was done right, like counseling given, and D is the total number of opportunities, total patients.
Okay, X plus 1, D plus 2. How does that help the 1 out of 1 case?
Well, instead of 11 equals 1%, it becomes 1 plus 1 divided by 1 plus 2, which is 23, or about 67%.
Ah, so it pulls that perfect score down a bit, makes it less extreme.
Exactly. It dampens the effect of those potentially misleading perfect scores from tiny sample sizes, making the overall benchmark calculation more stable and, frankly, more believable.
Okay, that's clever. So the method seems robust, but one thing strikes me. It seems focused on process indicators, right? Like, did they give the counseling? Did they prescribe the right drug? Not the ultimate outcome, like, did the patient live longer?
Yeah, that's a deliberate choice, and it often raises eyebrows.
It feels a bit counterintuitive sometimes. Aren't outcomes the main goal?
They absolutely are the ultimate goal. But focusing on process measures for benchmarking has some big advantages for quality improvement.
Like what?
Well, first, processes are generally more immediately actionable. A hospital can change a process for prescribing medications starting tomorrow. Changing overall mortality rates is much more complex.
True, easier to control directly.
Second, comparing outcomes, like mortality, fairly between different hospitals is really hard. You need complex risk adjustment because some hospitals treat much sicker patients than others. Process measures often don't need that level of adjustment, or it's simpler.
Okay, avoids a big statistical headache.
And third, process measures are often more sensitive for detecting differences in quality. Small improvements in processes might be visible sooner than changes in big outcomes like mortality. The underlying bet, essentially, is that consistently doing the right processes will lead to better outcomes over time.
Right, it's a leading indicator, assuming the process is actually linked to good outcomes.
Precisely. That link needs to be there, of course.
So wrapping this up then, this 1998 paper, Kiefe et al., it really laid out a blueprint for moving benchmarks from subjective guesses to something objective, data-driven, and actually achievable.
Yeah, it provides a practical path.
Yeah.
It's about finding that verifiable excellence that already exists and using it to lift everyone else up. Continuous quality improvement based on reality, not just wishful thinking.
And not just in healthcare, presumably. This way of thinking seems applicable much more broadly.
Absolutely. And that leads perfectly into a final thought for you, our listener. How could this framework, this idea of identifying truly achievable, data-backed standards apply in your world? Whether it's your job, your hobbies, your community work. How might you use this kind of thinking to set better goals and measure success? Especially when you're dealing with maybe messy data or just that desire to find genuine, replicable excellence. Something to think about.